Hello everyone, Dr. Ed. Today we'll talk about echocardiographic cardiac tamponade findings. The size of the pericardial effusion can be from acute to subacute to chronic, and if it's chronic, it will be present for greater than 3 months. And the size is divided into mild, moderate, and large, depending on the measurements of the pericardial effusion, as shown. These are some of the echocardiographic features and their sensitivity and specificity. Large pericardial effusion with swinging heart, late diastolic early systolic collapse of right atrium, duration of collapse of right atrium as ratio of the cardiac cycle length greater than 1/3, diastolic right ventricular collapse, respiratory changes during inspiration of the mitral E velocity greater than 30% decrease, or tricuspid velocity greater than 60% increase, IVC dilatation greater than 20 millimeters, and less than 50% reduction of diameter with respiration. This is a surrogate to POCUS paradoxes. This suggests that the longer the collapse of the RA, the more likely it's suggestive of cardiac tamponade physiology. This is an example of pericardial effusion, and you can see that it is a large effusion. And when you pause the video to measure it, from here to here, it's about 2 to 3 centimeters. So as mentioned before, if it's greater than 2 centimeters, it is a large pericardial effusion. Diastolic right ventricle collapse can be seen in all 4 cardiac windows. Here is an example of right ventricular collapse. You can see that when the heart is in diastole, or when the heart is trying to relax, the right ventricle is collapsed. This happens because the pressure outside of the heart chamber is higher than the pressure inside of the heart chamber when the heart is trying to relax or expand. Systolic right atrial collapse is another echocardiogenic tamponade physiology feature. The lowest pressure in the RA is during systole or late diastole during atrial relaxation, and that is the earliest echocardiogenic sign of tamponade. It is best seen during apical 4 chamber view. Here is a video of RA collapse. It's hard to see, but if you pause the video during systole, there should be an invagination of the right atrium like so. During cardiac tamponade, the mitral valve and tricuspid valve inflow velocities changes during respiratory. It is obtained using a pulse wave Doppler gated placed at the tips of the valve leaflets in apical 4 chamber view. And when it is measured during inspiration, there should be a 30% decrease in mitral valve inflow velocity or a 60% increase in tricuspid valve inflow velocity. And then you have to sample the tallest E wave peak and compare it to the lowest and calculate the percent change. Here is an example of the mitral valve inflow with change in respiration. This is an apical 4 chamber view, and these are pulse wave Dopplers gated right at the tips of the mitral valve. Then on the screen you see something like this, and here is expiration, and this is inspiration, goes up to expiration. So you calculate the difference in terms of percent change. So here the picture says greater than 25% change, but I use 30% change with inspiration in the mitral valve as measured by pulse wave Doppler. That is a surrogate for decreased left heart filling, which correlates to a drop in systolic blood pressure greater than 10 millimeters, also known as POCUS paradoxes. And this is just the echocardiogenic feature of that. A plethoric IVC is very sensitive for cardiac tamponade. Therefore, if there is no enlarged IVC, then there is less likely that there's cardiac tamponade physiology. So this is about, I would say, about 3 centimeters. So this is about 3 centimeters in diameter. You can estimate the right atrial pressure depending on IVC diameter and its collapsibility with respiratory variation. As shown here on this table, if the IVC diameter is less than 2.1 centimeters with greater than 50% respiratory variation, you can estimate our right atrial pressure to be 3. If it's less than 2.1 centimeters with less than 50% respiratory variation, the right atrial pressure is 8. If it's greater than 2.1 and greater than 50, it's also 8. Greater than 2.1, less than 50, and that is 15. In summary, tamponade is a clinical diagnosis, and echocardiography is a helpful tool. Findings on echo include a large pericardial effusion, diastolic RV collapse, systolic RA collapse, a plethoric IVC with minimal respiratory variation, exaggerated respiratory cycle changes in mitral valve and tricuspid valve inflow velocities, which are surrogates for POCUS paradoxus. These are my references. If you thought this video was helpful, please like, subscribe, and look out for my next video. Thank you for watching.